Thank you and welcome again to today, Monday the 10th of August 2026, for another series of the Moments of Fruitfulness. Remember, we are coming to you with Moments of Fruitfulness as an opportunity for you to learn all that you require to know so that you can be fertile and you can multiply even as God has wished for you. As a couple, your marriage is a blessing, and having children is also a blessing from the Lord. That's what God had desired for you. But possibly you are having a challenge and there is a delay. We are coming to you today to give you more information on the things that will help you achieve your desired biological role. Let me say that in this moment of fruitfulness, our theme is about this time next year. About this time next year, you shall carry your babies. The Lord said made this same statement to Sarah, and also Elisha made this same statement to the Shunammite woman, and they all got their answers. And we are making this same statement to you that about this time next year, if you work with us and if you listen to this series and you follow the necessary steps, you will carry your babies. And that's the theme of our message in these moments of fruitfulness. In this series 002, we will discuss the causes of infertility generally, and then we will lay emphasis on the Tubal factors for this particular series. Subsequently, we will take the male factors and other factors, and we will exhaust all the causes of infertility so that you will actually know exactly where your problem lies. Let's say that in discussing the causes of infertility, we are looking at the causes that could come from the woman or the causes that could come from the man. So the wife may have the challenge alone, or the husband may have the challenge alone. In some cases, both husband and wife will all have a reason or a challenge. And that's why the infertility results. In some situations that we know, which we call in the medical field unexplained infertility, there is no explanation. The woman is perfectly normal and the husband is perfectly normal, but they can't have a child, and we call it unexplained infertility. These are all the areas where spiritual factors play a part and other things beyond the medical realm. Let me also say that in recent times, and from the studies we have done, male infertility seems to be on the increase, and is actually the leading cause of infertility. And I want to let the men know that it is important that you are part of the arrangement. Whenever there is infertility in a family, the couple should be investigated together, because it is the responsibility of both parties. In the causes of male infertility, we call it the male factors. We know it could be from the sperm, it could be from the erection, it could be from the blockage in the passage, the systems through which the sperm is transported. And in some cases, it could be from stress. So we will take these different causes in our subsequent episodes. Sperm challenges, erection problem, we call it erectile dysfunction, blockages in the passages or transportation of the sperm, and stress-related factors. We will discuss all that. And the female factors, you also know that it could be caused from the uterus, from the fallopian tube, from the ovary. These are all parts of the female reproductive system. So the uterus, the fallopian tubes, the ovaries, even the peritoneal cavity and the higher centers. And also stress-related factors could also play a part. So these are the female factors. So the female reproductive system is involved. And so we're also going to take these different factors one after the other in the series as we move on. Every Monday, we'll take a particular factor. This today, we're taking the Tubal factors as the causes of infertility. We're going to discuss the blockage of the fallopian tubes, the adhesions, the sapropharyngitis, the hydrosapiens, and all that you can think of. In the female factors, the Tubal factor is the commonest cause of female infertility. And it's important we address it, and address it very well this night. The fallopian tube is actually the smallest part of the female reproductive system. It connects the uterus to the peritoneal cavity. And so you can actually say that the fallopian tube actually connects the abdominal cavity, which is the pelvis of the woman, to the outside. Because the fallopian tube is open and it goes through it, gets to the uterine cavity, to the cervix, to the vagina, and the outside. So that is the connection. So everything that moves from the vagina can actually move straight and go through the fallopian tube into the peritoneal cavity. The fallopian tube and the infertility. The three properties of the fallopian tube, because we are looking at the fallopian tube. The fallopian tube and fertility. Let me explain further that the fallopian tube has three particular properties we look at when we are trying to do investigations to find out if there is any problem with the fallopian tube. One is the fallopian tube open? We talk about the patency of the fallopian tube, whether it's open or it's blocked. We also look at if the fallopian tube is free. The fallopian tube is meant to be free, mobile. It can move from with the ciliary processes so that it can actually pick the egg whenever the egg is released. And the third aspect is whether the fallopian tube is healthy. And when we look at the health of the fallopian tube, we are looking at the internal contents of the fallopian tube. The inner lining of the fallopian tube is lined by ciliary processes which beat towards the uterine cavity. And these are the movement that takes the egg from the outside, pick it up from the beginning of the fallopian tube and move it to the uterine cavity. And so that is a very important aspect. And a healthy fallopian tube will have these different properties. It must be open, it must be free and can move from end to end, and it should be healthy with the activities of the ciliary processes working very fine. So if we look at the challenges or the problems or the things that can happen to the fallopian tube, based on these functions we have mentioned, the first is that the fallopian tube could be blocked. And when it's blocked, we call it tubal blockage. The blocking of the fallopian tube can actually occur at 3 points. At 3 points. The blocking of the fallopian tube can actually occur at 3 points. So that when you look at the fallopian tube, it could be blocked at the beginning, which is the connection between the fallopian tube and the uterus. We call it the proximal block, the cornual occlusion. It can also block in the middle, the isthmic portions of the fallopian tube. So that is a medial block. And it can also block at the end. When it blocks at the end, which is at the fimbrial process, we call it the distal block. Each of these blockage can actually give us different presentations. A typical presentation for the distal blockage, which is very key and very important, and we'll discuss a lot of it, is what we call the hydrosapiens. Because when the tube is blocked at the distal end, at the fimbrial end, It simply means that the secretions inside the fallopian tube gets accumulated in the fallopian tube, and the fallopian tube swells up. We call it the hydrosalpinx. So the fallopian tube develops a kind of swelling, and then, of course, when that happens, it cannot pick up the egg, and it traps all the fluid inside it, and this same fluid over time becomes toxic, and this same fluid can track back into the uterine cavity. And of course, such a fluid tracking back into the uterine cavity becomes toxic to anything that comes inside the uterine cavity. The second aspect is when the fallopian tube is not moving freely. And what can cause the fallopian tube not to move freely is what we call adhesions. Adhesions are strands or collagenous materials that bind the fallopian tube either to the ovary, to the uterus, to the intestines, and every other thing, and they cannot move freely. When these things happen, we can only identify these things through a laparoscope. We call it laparoscopy. And if you identify it, it's important because it's a challenge. This fallopian tube cannot move freely to pick up the fallopian tubes, and you can actually release these adhesions. If you're able to see the pictures, you can actually see the adhesions that are there. And so these are the things that can affect the fallopian tube. But when we look at it again, the next question would be, what is the cause of this tubal damage that we are talking about today? What brings about this damage? When the tube, from infancy, from the time the child was born, the fallopian tubes were healthy, but along the line, these things happen. And so I must say that the first and most important cause of tubal pathologies or tubal damage is infections. Infections can come from several areas, and it's important we remember that. First and very important is sexually transmitted infections. Sexually transmitted infections. The name is clear. It says it's infection, bacterial infections, viral infections transmitted through the sexual contact. We remember the chlamydia, we remember the gonorrhea, we remember the staphylococcus, and others. And these affect the fallopian tube. This is very important. Sexually transmitted. There are so many more, but I've just mentioned these few to remind you that every act of sexual exposure carries the risk of an infection. Even HIV and the rest of others, even hepatitis, human papillomavirus, and the rest, they are all infections that can come through sexual contact. The second aspect of it, these infections we are talking about, is pelvic inflammatory disease. Pelvic inflammatory disease comes from so many other variables, but it simply means that there is inflammation of the structures in the pelvis. And these structures include the uterus, the fallopian tubes, the ovaries, and the rest. And they are all the things that are in the pelvis. And we now call it pelvic inflammatory disease. It is also a killer, because when it happens, all the different components of it could come from ascending infections, from vaginitis to the cervix, we call it cervicitis, to the uterine cavity, we call it endometritis. When it gets to the fallopian tube, we call it salpingitis. So all these things put together, and they are pelvic inflammatory disease. We also look at cases of abortions. Infections can follow abortions or miscarriages, and we look at it, call it post-abortal infections. This is very important, and that is why every act of termination of pregnancy could lead to infections that can actually cause infertility. And that's why some people will say, oh, doctor, when I was single, I had conceived and terminated the pregnancy. And I mean, when I was single, it was easy for me. Once I sleep with a man, I conceive and I terminate the pregnancy. But now I have been trying to conceive since I got married, and it's not possible. It is possible that those periods or those terminations, infections had gotten into the system and then caused the tubal blockage. When there is an infection, The first structure that is commonly affected is the fallopian tube, because fallopian tube is the smallest aspect of the reproductive tract. And so it can easily be blocked. There are other infections, even post-delivery infections. If you have a delivery in unhygienic environment, you could actually pick up infection from there. And this is very important to a lot of women. Be careful where you go to have your delivery, because there are people who have delivered, they've delivered the first child and they've not been able to conceive again. And the woman will be saying, oh, but I've had my first delivery. Why? And I had a very safe delivery and I delivered like the Hebrew women. But why is it that I can't get pregnant again? By the time you run assessments on them, you find out that the fallopian tubes are blocked. What happened? Infection. Puerperal, we call it puerperal sepsis. Puerperal infections, which is post-delivery infections. And this is very important. And so every woman must be careful where you go for your delivery. There are other infections, we call it vaginal infections, and I'm going to mention it in the next few minutes. But before that, let me talk about the post-operative causes. What we mean by post-operative causes: pelvic operations, operations like cesarean section, operations like myomectomy, operations like even laparotomy, even simple complicated appendicitis, and all these operations, pelvic operations, they can actually lead to the formation of adhesions. And this is very important in our environment today, because these adhesions, like I mentioned at the beginning, affect the fallopian tube by tying it up and preventing it from moving freely to pick up the eggs when the eggs are released. And when it happens, that becomes a problem also. And there is one condition that we know that is very common now, and we're diagnosing it more and more often, and we call it endometriosis. In endometriosis, there is the endometrial tissues present in the peritoneal cavity, or else outside, once it's outside uterus. And this causes what we call endometrioma. And besides the endometrioma, it causes adhesions formation. And then the fallopian tube, the ovaries, the intestines, and uterus can be gummed together. When you do simple HSG, the uterus, the fallopian tubes will be seen to be open, because a lot of times in endometriosis, the fallopian tubes are open, but they are tied up that they cannot function again, as if to say somebody used a rope to tie up something. So this is very important. So past pelvic operations and endometriosis are two important areas that, apart from tubal blockage, they cause adhesions, post-operative adhesions, and general adhesions that affect the fallopian tube. Now let me mention a little bit more about these adhesions, how these adhesions come, because you'll be wondering why. But these adhesions, I've mentioned that they can come from all the different pelvic surgeries we do: fibroid operations, cesarean sections, ovarian cystectomies, that's operations in the ovary, laparotomies in general, and everything. And this happens because a lot of places, because of saving costs, they use poor operative techniques. Because of saving costs, using inferior materials, using poor sterilized instruments and equipment, and even poor operative techniques, inappropriate handling of sensitive reproductive organs, and of course, sometimes there are today unqualified personnel. We even proceed to do certain operations. Cesarean sections are meant to be done by experts, gynecologists. The same thing with uterine fibroids and every other thing, myomectomies, safe and sound. But today, everybody wants to have a bite at some of these operations, and it is risky. And therefore, as a woman, as a mother, as a husband, when things like this are expected to happen, go for the best. Go for a facility that can offer you, because these are things that will affect the reproductive function of the woman or of the young girl. When I mentioned that there are habits that can affect the that can create infections. Those habits are things I will mention quickly because it's important. I've had the in my practice, a couple married as virgins, but the lady could not conceive. And by the time the lady was assessed, we found out that the fallopian tubes were blocked. And if the fallopian tubes were blocked, what is it? How did it happen? Because possibly one of these factors I will mention now led to an infective process. And from the infection, the fallopian tubes got blocked. And so, wiping, there are 3 of them. We call it www. Your website, really. Wipe. How do you wipe? How do you wash your undies? And what do you wear? Particularly your inner wears. And so when we talk about cleaning, when you go to the toilet, remember, if you look at this model that I'm showing you here, you see this model. This is the anus. Okay, you can see that is posterior. This is the vagina, is anterior or in the middle, and this is urethra. So when a young lady goes to the toilet, I expect that if you want to clean, this is the anus. It's meant that you clean from front to the back so that you wipe away everything, the fecal matter, posteriorly, and throw it away. And that way you will not contaminate yourself. But a lot of people, in a haste, will wipe from posterior forward. So when you wipe in the forward direction, you collect the feces from the rectal area, from the anus, and you smear it on the vagina as you take it out. And that can cause vaginal infection. And that's why some people will keep saying that this my infection, I've treated it and treated it and treated it, it's not going. But it may be that you are recontaminating yourself every time. So it's important to wipe when you go to the toilet. You wipe from the front to the back and not from the back to the front. A very important principle in wiping. Then the next thing is, how do you wash your undies, particularly? And this is very important. It's important to wash, even if you wash with detergent, you must rinse it completely, rinse it so that all the detergents will go off. Very important. A lot of people will just wash, maybe because they don't have enough water where they are, and they just dry it up that way, thinking that when it is dry and when they wear it safe. Look at, when you leave some detergents on your underwears, when you put it on, because of heat and sweating and every other thing, your body absorbs that detergent. And I tell you, in the vagina, there is a natural flora that is there that protects you from infection. When you keep sending these detergents into your private area, into your vagina, it kills your natural flora, and therefore the infections will overgrow. And this also is one of the reasons why those who use detergents to wash their vagina, every time they say, look, I need to wash, and with some people even use strong detergents. No, that is a wrong practice. What you have to use at any point in time is plain water, clean water, and use it and wash. And this is very good. The last is what you wear. Again, during menstrual flow, a lot of women, maybe because of the cost of the sanitary pad and everything, we choose to use toilet rolls to serve as their sanitary pad. This is also wrong because toilet roll is not sterile. It is not sterile. It is not prepared in a sterile environment to make it infection-free. And therefore, it's important you continue to use the sanitary pad, and there are different varieties that are available in the market. Even when you cannot use your sanitary pad, if you choose to use any other thing, and this is just the exception, if where you are looking at the exceptions that the sanitary pad is not there, then it means you have to buy a plain white cloth so that will help you know when it is dirty, and wash it very well, then iron it, and then keep it, and then you can use that. That can actually help you, but preferably at all times use the sanitary pad. When you use anything that is contaminated, anything that is not clean, anything that is not proper, and you put it in as your sanitary pad, what happens? Your body absorbs the infection, and the infection gets into your vagina, and it will cause damages in the reproductive system. So you must be careful, because this is an area you don't want to pick these unnecessary infections, and at the end of the day you say, look, I don't know where I got this infection from. I married my husband as a virgin, and the rest of others. Again, you say to yourself, look, I don't know how these things came about, but it is your personal hygiene. Your personal hygiene must be very, very important and well taken care of. Finally, let me look at the symptoms. How do you know that you have this infection we are talking about, so that you can actually take necessary steps to and to prevent it from getting into the stage of damaging the reproductive system? One is vaginal discharge. Once there is an infection, one of the things that will happen immediately is that the discharge that comes out from the vagina will change. Remember, if you know yourself very well, immediately after your menstrual flow, let me say your menstrual flow is a blood that is being discharged. So after the menstrual flow, there follows a dry period. So there won't be any discharge. After the dry period, then the discharge that comes like a pap starts, and then comes the egg white discharge, which is the ovulatory mucus. From the ovulatory mucus, it tidies up to another pap-like discharge before eventually you become dry again and the menses come. This is a cycle that goes in, and you need to remember that. The discharge can also come with itching. So you need to know the type of discharge that you have naturally as a young lady. And from there, you will know when the abnormal one comes in. And once you have the abnormal one, get to a hospital, get treated immediately, and it will not cause a problem for you. But when it's delayed, what happens is that the infection will migrate and go into the upper genital tract, which is the uterus and the fallopian tubes, and cause the damage. Then when the infection has climbed up, you start having what we call lower abdominal pains. And those lower abdominal pains, particularly in the pelvis, we call also, it will translate to what we call chronic pelvic pain. Always you are feeling pain there. Even the hotness of the abdomen, every time you say my waist is feeling so hot, this is infection. And if you get to a hospital, this can be taken care of and you'll be treated very well. Others may also complain of crawling sensation every time something is crawling around in your waist and everything, and you don't know what it is. These are evidence that you have picked up an infection. But let me look at the tests that we can do to find out that there is a problem with the fallopian tube. One is particularly to look at whether the tube is open or is blocked, and we say hysterosalpingogram. We call it the HSG. It's one of the popular tests. But that tells you only whether the tube is open or it's not open. We also have the sonohysterogram, which we do with ultrasound. We use ultrasound, inject a saline, and we take our ultrasound pictures. There you will know whether the tube is open or not. These particular investigations are very important. But I want to tell you, you don't need to do HSG, hysterosalpingogram or sonohysterosalpingogram, twice, 3 times, 4 times, and every time you go to a hospital, they ask you to repeat it. If you have done it once, you have done it. And if you have done it once and you are still not getting pregnant, we take you to another level where we do another test that can give us more information beyond patency of the tube. And that is the laparoscopy. In the laparoscopy, we can actually determine whether the tube is open or blocked, and then whether the tube is free and where there are adhesions or no adhesions. So laparoscopy tends to give us more information of the state of the tubes. It's open, it's free, and it's healthy. That's what laparoscopy can add to. So what we usually advise women is that once you have done a hysterosalpingogram and it's not you're not still getting pregnant, then you must get to a hospital that can offer you laparoscopy. We call it laparoscopy and dye test. And once that is done, you can find out the state of your tube. And it is actually the standard investigation, the standard of care for challenges with the fallopian tube, and that's what you should do. I don't know, but if you can see the pictures, I've given you some ultrasound pictures and some HSG pictures that will show the tube when it's blocked, and of course the laparoscopy pictures that will show the blocking of the fallopian tubes. What are the consequences of these pelvic infections when it affects the fallopian tube? Of course, first is chronic pelvic inflammatory disease. You now have a chronic inflammation in the pelvis, chronic pelvic pain every time you have pain in your waist, and of course the vaginal discharge that has failed to be treated because you have not handled it very well. And of course, from this comes the infertility due to the damage to the fallopian tubes. Again, it can also affect uterine cavity, but I'm not talking about uterine cavity now. That's why I'm concentrating on the fallopian tubes. It's a damage to the fallopian tubes. We have salpingitis, inflammation of the fallopian tube. From there, the fallopian tubes swell up, and we call it hydrosalpinx, or eventually the fallopian tubes gets blocked, and we call it blockage of the fallopian tubes. All this can happen with infection process. And when the fallopian tube is damaged, part of the consequences that can also happen, particularly if the tube is damaged but it's not blocked, you can have ectopic pregnancy resulting. So anytime ectopic pregnancy results, there has been a damage to the fallopian tube. Damage either through the additions or the cilia process, but at least it's a pattern. And that damage can lead to ectopic pregnancy. And these are the challenges that can happen. For us, treatment is important. And the treatment here is to make a diagnosis of this early. That's why I say once you have this discharge and you know your normal discharge and the exchange, get to a hospital. And when you get to a hospital, be treated very well. The proper thing is to do some investigations, particularly vaginal swab and endocervical swab. And when these two are done, we can actually pick the particular infection that is the offending organism that is causing this the particular infection we are talking about, and the particular organism that is causing the infection. And when that is done, proper antibiotic therapy. And what do we mean by proper antibiotic therapy? Duration, we choose the antibiotic that the organisms are sensitive to, and we also know the duration that it will take place, the duration you will take the antibiotics. Very important. Remember, this has to be done by a qualified medical personnel. And I say avoid self-medication. This is one of the killers. Avoid self-medication. You go to the chemist and say, mix drugs for me, and the chemist will just mix all kinds of antibiotics for you, and you take it for 3 days. Let me tell you, in the first 3 days, the vaginal discharge may reduce significantly, and you say, I am cured. You're not cured at that point in time, because there is still a smoldering process going on. Once infection is being treated in this reproductive tract, you take antibiotics a minimum of 7 days, and we even say in most cases 10 days. So it's important that you take it for the correct duration, take the appropriate organisms, and take the appropriate antibiotics, and take the appropriate combination. This is important. And I summarize by saying a stitch in time will save 9. If you treat it on time, you will save yourself the challenges of having your reproductive tract damaged. Again, preventing these sexually transmitted infections, we are talking about risk elimination. And in the risk elimination, when we say prevention is better than cure, is to advise a young lady to do sexual abstinence until you get married. And when you cannot abstain, then use protection. And this is very important. For you that is already married, commitment to your faithful partner is very important. That can also prevent these infections from coming your way. And so, to summarize this is to say a good sexual behavior is what you require to prevent yourself from getting sexual transmitted infections. But are there solutions to these challenges with the tubal pathologies? Yes, there are this tubal damage, there are solutions. And I want to talk about the solutions now, because I know that's what you've been waiting for, and you're listening to hear whether, if these things happen, what can be done? When the fallopian tube is blocked, particularly if there is a proximal block, I tell you, there are several steps we can take to take care of this fallopian tube that is blocked. One of those steps is flushing of the tubes. And we do this preferably under a laparoscopy setting, because when you do a laparoscopy, you can actually flush the fallopian tubes, and as you're flushing, you're seeing it immediately to know whether this flushing is working. I know there are a lot of people who have practiced the aspect of not flushing the tubes blindly. Let me tell you, flushing the tubes blindly is not adequate, because you may not know exactly whether you have succeeded or you have not succeeded. So what is important is to flush the fallopian tubes, preferably under laparoscopy setting, and then if you do it and the tube opens, you will see it immediately. And that's one of the first things that can be done when the fallopian tube is blocked. The second aspect of it is that we can actually do what we call tubal cannulation. We can actually open up the fallopian tubes by using a special technique. We call it a cannulation wire that we can thread through the cervix, through the uterine cavity, and to the fallopian tube, and this can actually open up the fallopian tube. We do this under another setting of hysteroscopy and laparoscopy. We call it hysterolaparoscopy. You see, through there you can actually bring the how do I put it now? You can actually go through the hysteroscope, thread the wire, and get to the fallopian tube and use it and open the fallopian tube. So this is where it is. Tubal cannulation by hysteroscopy and laparoscopy. So these two options can work for you, and they are very good when it is the proximal end of the fallopian tube that is blocked. If this cannot work, you've tried it and it's not working, and so the fallopian tube remains blocked, the next is assisted reproductive technology, when we take you to in vitro fertilization. Because the fallopian tube, what's the function of the fallopian tube? It is this place where the egg and the sperm meet each other and form the embryo, and the embryo travels through the fallopian tube for 4 to 5 days into the uterine cavity. And so that function, we can actually perform that function outside today, where we take the egg, take the sperm, fertilize it in the laboratory outside, and transport it and transplant it into the uterine cavity again. And that's actually in vitro fertilization. So if you're listening to me and for instance you've been informed that you have blocked fallopian tubes, proximal blockage, and you have done everything, you don't need to continue wasting your time. All you need to do is to consider assisted reproductive technology, and you will get your pregnancies as soon as possible. When the fallopian tube is blocked at the end, we talk about distal blockage and we have the hydrosalpinx, we can actually do surgeries and open up the fallopian tube again. We call it gutter salpingostomy or cuff salpingostomy, and these surgeries are preferably done through laparoscopy again. In the past, we used to do it through open surgery. We cut you open, go in there, fiddle with our hands and everything. But it's been found that such surgeries, because of the delicate nature of the fallopian tubes, we end up creating more adhesions and has not been very successful. Okay? Today, these surgeries are done through pinhole surgery, minimal access surgery, laparoscopy surgery that we call it. And when you do it, you don't put your hands there, you just put some gadgets and use the gadgets and handle the fallopian tubes. I tell you, the success rate in these surgeries is very high, closing up to 80%. You restore the fallopian tubes, and the fallopian tubes can work for you again, and you can conceive again. So salpingostomy could be done, which is opening up the tube at the distal end so that the tube becomes open again. Besides salpingostomy, you can actually say to yourself, if the tube has been damaged completely and you have been recommended to do assisted reproductive technology, IVF, because I know this question will come. Somebody will ask me, if I have hydrosalpinx, will I still do IVF? Can I still succeed? Does it affect the result or the success rate of my in vitro fertilization? Yes. If you have hydrosalpinx and the tubes are swollen, it can affect the success rate of your assisted reproductive technology. And in that instance, what can you do? We usually talk about clipping the tube or doing a salpingectomy, removing the fallopian tube, so that the IVF will be very successful, simply because the fluid that accumulates in the fallopian tube tracks into the uterus and is toxic to the embryo that you plant inside the uterine cavity. And you would, from all I have said to you now, you find out that most therapies on the fallopian tube, we do it through the laparoscopy surgery. Even when the tube is held down by adhesions, these adhesions are caused by surgery, open surgery, pelvic operations, and infections and everything. The best way to remove these adhesions again is laparoscopy surgery. I've mentioned this repeatedly. So it simply means that open surgery is no longer recommended for treatment of challenges with the fallopian tube, because you will go there and worsen the outcome, because you will cause more adhesions and you do more damage to the reproductive system. Laparoscopy surgery is the preferred approach. And of course, laparoscopy surgery is available everywhere, all over the world, even in our country, Nigeria, and any other place. All you need to do is to ask, and you will get a reference to a good center that will offer you laparoscopy surgery. And finally, the best result, or the final approach is, like I said, assisted reproductive technology. When all has failed and you have done all the conventional treatments and you've tried the surgeries and they are still not working for you, and I say the answer is assisted reproductive technology. And so, if you have heard me this evening, what have I succeeded in saying to you? That tubal factors cause infertility, and they are best diagnosed and treated with our laparoscopy. You can actually do your HSG, but I say if you have done a HSG the first time, hysterosalpingogram, please X-ray. Don't go repeating it again. All you need to do is to move to laparoscopy, and when you do laparoscopy and dye test, you will find the rest of the answers. And again, when you have done this, you can have the fallopian tube pathologies can also be treated by laparoscopy surgery. When these things are not applicable, we now move to assisted reproductive technology, that where laparoscopy ends, assisted reproductive technology takes over. You can do your IVF, you can do your in vitro intracytoplasmic sperm injection, and all the rest of the range of assisted reproductive technologies that we have, and you will get your answers. So, in summary, we can say that with reproductive medicine and assisted reproductive technology, combined with a laparoscopic diagnosis of tubal factors, that everything that can happen to your fallopian tubes, we can make the diagnosis, and we can actually treat it, and we can actually help you to achieve your pregnancy. So if you follow what I have said to you today, it means that about this time next year, if you have tubal pathologies or tubal damage this year, it simply means that following these steps, you can get your solution, and about this time next year, you can carry your babies, because that tubal problem will be solved, and then you will conceive, and then you have your babies. So I want to say thank you for listening, and I'm ready to take your questions, and you can type your questions on the platform. If you're following me on TikTok or you're following on the Facebook, if you type your questions there, I'll read through your questions and give you answers to help you and to solve your problem. But remember, you can receive the answers that you're seeking. Reproductive medicine is here with the answers. We can diagnose all tubal challenges you have, all your causes of infertility, and there are treatments available, there are solutions, and you can conceive again. About this time next year, you will carry your babies. Thank you, and God bless you.
Thank you very much. We will take questions now. Someone is asking, can a blocked fallopian tube be treated without surgery?
Yes, that's a very good question. You say, can a blocked fallopian tube be treated without surgery? And I said, the only treatment of a blocked fallopian tube that can come without surgery is flushing of the tube. But even in that flushing, I said, for that flushing to be very successful, or for you to confirm that you've succeeded or you've not succeeded, we usually do it under the setting of a diagnostic laparoscopy, and we do that flushing. Besides that, it means that the treatment is assisted reproductive technology for you to get pregnant again. That's also not surgery. So if you don't want to have surgery for the fallopian tubes, it means either the flushing sorts you out, or you now do assisted reproductive technology. The other word we use for this flushing, I keep saying flushing, but is a common language for it, but we call it hydrotubation or chromotubation. These are all the possibilities. Thank you.
Okay, thank you. Another question. If one tube is blocked, if one tube is open, can natural conception still be attempted?
Oh, beautiful. This question is very good because I did mention it while I was going through the teaching. God has, in His infinite mercy, provided us with the woman with two fallopian tubes. So you have the left and you have the right. So if one of them is blocked, particularly either left or the right, yes, the answer to your question is yes. You can still conceive with the other two. I've treated clients. I've had clients who had ectopic pregnancy previously, and one of the fallopian tubes that was involved in the ectopic pregnancy was cut off. The person still conceived 4 times and had 4 pregnancies and deliveries with the only remaining tube. So it's possible, and that is why when you have a challenge with the fallopian tube, it could be taken out because it has a spare, being 2. If you look at everything in the body, the eye, we have 2. If one eye is damaged, you can see with the other eye. The ear, we have 2. If one ear is affected, you can hear with the other ear. The nose, we have, if one nose is blocked, you can breathe with the other nose. So in the same way, God has given the woman 2 fallopian tubes and 2 ovaries. If one side is affected, you can still achieve your pregnancy with the other side. Thank you.
Okay, so this is just a follow-up to the question. She's asking, she said one of my tubes are blocked. Is there still need for laparoscopy or tube flushing?
That's a very good question. If one of the tube is blocked, what to do is to find out what is the status of the other tube. So whatever investigation that you did that showed that one of the tube is blocked, you need to go further. And the best test for you in this instance is to do a diagnostic laparoscopy and dye test. And when that is done, the other tube will be examined appropriately, whether it's open, whether it's healthy, and whether it's free. And that will tell you that you can actually conceive further with this remaining fallopian tube or not. So laparoscopy and dye test is recommended for you.
Someone is asking, how do I know if I have blocked tubes?
How do I know if I have blocked tubes? A very good question again. The way to know if you have blocked tubes is 1, you have married and you're trying to conceive and you have not been able to conceive. So we call it infertility, and we define infertility as inability of a couple to achieve a pregnancy 12 months after their marriage, having exposed themselves to unprotected regular sexual intercourse. So if you've done all that and you are still not able to conceive, then it means you have a problem with your reproductive system, and so you subject yourself to evaluation. So to know that you have a blocked fallopian tube is to do the test. We call them Tubal patency tests. And I started by saying one of the common ones is hysterosalpingogram, HSG. When you have done HSG, it will tell you whether your tubes are blocked or not. The next is sonohysterosalpingogram using an ultrasound. If you do it, we usually inject a fluid into the womb and use an ultrasound to follow it, and we can see the movement of the fluid. You can also use it to know whether the tubes are blocked or not. And the final test, and the best of them all, is diagnostic laparoscopy and dye test. So you can use any of these evaluations and find out whether your fallopian tubes are blocked or whether they are open. Thank you.
Okay, so that's our question. All the questions we have today. We can now conclude this session.
Thank you for the questions, and I want to appreciate and say to you that good, we are coming to you live, and we've been able to talk about Tubal factors now so that we can balance it. In the next series, we are going to talk about one of the male factors or one of the male causes of infertility, so that we take a female factor, we take a male factor, and balance it up. So next section, Monday next week, we'll be talking about male infertility, and particularly sperm pathologies, challenges with the sperm, so that we know what we can do to help our husbands and every other person. After that, we will now talk about the uterine factors that are affecting the uterus of the woman, fibroids and the rest of others, uterine synechias and the rest, and so many of them. So I want you to continue with us. You can follow our channels, Facebook and TikTok, and get all the information that you need to get. Our desire for you in this moment of fruitfulness is that you shall be fruitful, even as God had made it, even as God had established it for you. And so that's why we say, about this time next year, you shall carry your babies. You can also reach me any other time through any of these platforms, and we will take your problem personal and solve it for you. The important thing is that you will receive your solution. God bless you, and thank you, and see you next week.